and the Executive Director of the BC Renal Agency. In today's talk, Dr. Levin will explain her work in setting up clinics in BC for post-COVID recovery and why integrated care is so important in this context. So over to you, Dr. Levin.
Thanks very much, Michael. I think everyone can see my screen, can you? Yes? Can you all see it? Just nod.
Yes,
Great.
yes.
Okay, thank you. So thanks very much. And this is actually a labor of love in many ways by lots of people, induced by the pandemic, if you will. But thank you very much for asking me to speak about this, which is a BC example of interdisciplinary clinical care network for post-COVID recovery. My slides would switch. So this network is a case study for integrating research and clinical care, and within clinical care, patient-centered and patient-informed from inception, this clinical network, including researchers, clinicians, and administrators working together to try and integrate a care model and care providers. And so I thought it's quite pertinent, given the conversations that were just going on, that I could actually be asked to do this. So in the current time, doing what we've always done may not work. So we do need to modify and adapt. And this was an attempt to see if we could build something much quicker, much more integrated from inception in the context of COVID. So the background of this was that we wanted to develop and mature a BC network focused on patients who've recovered from COVID-19. So not the treatment, but rather those who've survived and are now 3 months out. The clinical care and knowledge generation and application needs a coordinated network approach. All the things that PJ Foray spoke about at the beginning is what we understood from that. And we needed very much to have participation across in BC. We have 5 health authorities so that we could actually ensure equity, rigor, and patient community centricity. Most importantly, we're dealing with a disease that we don't understand. So we have to improve that understanding and patient outcomes in real time. Want to also be sure that we're responsible for resource utilization and guide and educate healthcare professionals and patients based on the best evidence, but at the same time really enhance capacity in primary care, specialty interaction, because that we understood from the beginning was critically important. So how do you generate the evidence to inform the practice? So this is where science and care come together. So ideally, we, again, to a conversation that was in the previous session, systematic collection of information, right? So what we thought we could do is if everybody got the same information collected in the same way, in the same rigor, we would actually improve our understanding of biological consequences and mechanisms. We'd be able to identify patient profiles. We'd have responsible ordering of tests by actually looking at those that are important for surveillance, diagnosis, and monitoring response to interventions. And through that shared learnings, we would actually improve the management of complex patients, and from the inception, collaborate between specialties in primary care. So as researchers, we wanted to know about the short, medium, and long-term impact on patients, healthcare systems, and resource utilization for planning and policy purposes. We wanted to understand the progression of the condition and organs that are affected in the moment to determine the stability of those conditions or changes over time, and planning for transitions as people either got better or worse, and look at the impact of the infection on other conditions that were pre-existing, because these we know are quite important. So we wanted to coordinate care both in person and virtually, by ensuring that we had easy access to the right tests and avoiding unnecessary duplication, because by starting the system knowing the risks of what would happen if we didn't, we thought that was a good place to start, to access evidence-based care when available, and to ensure that patients had easy access to multiple specialists, the true interdisciplinary care component, including allied healthcare professionals. And we've got linkages with Rural Coordinating Center and the use of real-time virtual systems to really help enable that. We want to coordinate research within the context of that clinic, those clinical areas in terms of basic translational, clinical, and implementation science, so that also we could reduce the amount of burden on patients, avoiding duplication of forms and tests, which often are similar across clinical studies, drawing one blood sample and having it aliquoted for multiple various biomarker tests, and actually really help to bring the scientists, clinicians, and health policymakers together. And of course, sharing information so we can link the data from clinical care and research to inform long-term care needs, as I said before. And so this was really meant to be province-wide. For those of you across Canada or other places, BC only has 5 million people in it across a diverse geography. So it's smaller total geography than the size of Toronto. The components of the network, again, in an attempt to integrate all the different facets that we know are important, include not just the clinical programs that are health authority based, but also a race line, which actually helps clinicians, GPs, and others to call with, to ask specific people who now have had a lot of experience, best things, a provincial registry, guidance and education that was outward facing with and to general practitioners, patients, and specialists. And then, as I said, the research activities coordinated within a provincial research registry, a provincial registry data, leveraging the extended the existing protocols and research, and looking at informing best practices in real time. So the care coordination to establish these specific clinics is, I suppose, what some of you were talking about in the previous session, which is how do we actually do this across multiple jurisdictions where no one exactly wants to do it the same way, the education, the research coordination. So as of this month, there are 3 post-COVID recovery clinics in British Columbia. There is a best practices document, which actually describes the purpose of the clinic, what it's supposed to do, what it should be resourced with. We've engaged GPs in the Rural Coordination Collaborative that I spoke about, and other health authorities is ongoing. And these standardized testing schedules are embedded in each of the clinics, irrespective of how they're resourced. There are standardized clinical assessment tools, referral pathways, and guidelines, et cetera. And you can see a lot of these at the website there. And the notion is, if we coordinate that assessment and get them access to appropriate investigations, education, et cetera, and any individualized clinical care and long-term monitoring, that we will learn the most about this group of people and then be able to adapt, change, and modify in real time. And then the notion about the embedded research or the integrated research, as is apt for this conference, is the central oversight and ensuring of quality by the Provincial Health Services Authority. And then each regional program operates under the jurisdiction of its local health authority institution, but again, really attempting to launch this in a very collaborative way. Many of you know what a learning health system is. This is, if you will, a pilot project of a learning health system around a new disease to try and see if we can truly get people to understand this concept of having the recovery clinics, the integrated network, the health authorities and locations of the clinics, and then research as the fundamental, the foundation, so that we can really inform the community, the post-COVID patients who were positive, hospitalized, or otherwise, their physicians and specialists, but also people at risk for the future. There are a number of different sources in this province of British Columbia around COVID-19, and this is just a diagram that highlights for you that the data sets live at the Ministry of Health in gray, the PHSA in green, and then the regional health authorities in the white color. That actually speaks to some of the problems that the earlier session talked about, which is the multiplicity of sources of information to try and inform care. And then if you take all of that and then look at where we're trying to fill a gap is in this clinical care, diagnostic testing and treatments, the guidance for care post, and clinical research and trials to try and really make sure that we integrate this to support care. And so we are working with all of the different partners to really try and take advantage of the totality of data. We do have some support for the research, both capital R and small r, as I like to say, in these initiatives, and I've just listed them here for you, again, to demonstrate the collaborative and the necessary different facets that are required to actually do an undertaking like this. And then ideally, in a perfect world, we have a cost recovery program for additional work that people may want to leverage the data that we have. And then obviously there are some additional funding opportunities, such as through the NIH $1 billion post-COVID care recovery grant and the Canadian Immunological Task Force as well. So how do you enable care from the integration of research and care? Well, we've had a lot of challenges. And many of you in the previous session did speak to this. So we have multiple clinics, multiple health authorities, and different approaches today about privacy and human resources, which we've had to combat, but we're doing it in real time. And in that way, this really is a case study. We needed these clinics to organize quickly and have a standardized approach. And that added some complexity. And I can tell you there's still pushback about, well, do we really need to do those tests? Do we really need to collect the data in this location? We do not yet have investigators in every health authority, but certainly as this has been launching and gathering momentum, that is becoming much easier to identify. And enabling the resourcing of the clinics for clinical and research support at the same time has also proved to be a challenge, but again, something that we keep working on, and with the help of both Ministry of Health and research organizations within the health authorities, we're getting somewhere. We did have some of our solutions that I garnered from my role at the BC Renal, which is where we have actually a successful history of launching these integrated network of clinics and care paradigms that are fiscally responsible. We're trying to leverage that Provincial Health Services Authority network to have the stewardship of the data collected at the established clinics and have ongoing collaboration. And as I mentioned at the beginning, what has been remarkable is we've had patient involvement from the very beginning, and they sit on all aspects of this network, including the steering committee and within each of the different working groups. This is an opportunity to create a truly integrated network of access to care and research capabilities in the context of a new disease across a province. And we have been collaborating with everyone that we know, which of course, as many of you will know, gets very complicated. We're trying to describe and demonstrate the value proposition of this approach by reducing variation in care and testing. We've got historical control from before we had launched and truly got going. Ideally, we would reduce random visits to outpatient offices, emergency rooms, and walk-in clinics, and ultimately improve our knowledge, as I said at the beginning, of the long-term impacts of this condition for planning. Really, one of the other things, and speaking to Dr. Ferre's notion about pilot projects. This is, yes, a pilot project to see if we can establish a sustainable infrastructure for the future. This should be a good model for pandemics and public health emergencies, for post-hospital or ICU care, as a model of how one would learn the most about this group of patients while supporting them. I haven't spoken as much about what the clinical care offers, but it truly is a support for patients navigating where many of their primary care providers and specialists don't have any familiarity with the disease other than what they read, and to integrate research activities. You will have seen this article by Gord Guyot and colleagues in CMAJ, and I think that integrating research into clinical practice should be easier in this country. We're not that big, 32 million people, and yet for all the reasons that people spoke about, it is hard. And it would be interesting if you read this outtake, a Canada-wide consensus on emulating the UK achievement is likely to take time and may proceed piecemeal. So maybe we should have pilot testing in a few willing provinces, and perhaps what I've just described to you is one said pilot testing of how you integrate in real time around an unknown or now known entity, something novel and different. So we're trying to coordinate care, research, and education to optimize the outcomes for patients and healthcare systems in real time. And it's funny because I actually had put this together over the weekend and was thinking like, how do we define integration? So I looked it up, and defining integration is the action or process of successfully joining or mixing with a different group of people, which we've kind of done, and the action or process of combining two or more things in an effective way. So with that, I think in a funny way, we've tried to, in this network, integrate research and care, and integrate care models and care providers. And so perhaps are truly a living example, not yet finished, still a work in progress of integrating care. So with that, I just want to acknowledge all of the collaborators, including patients, clinicians, researchers, and administrators, all around this sticky little virus that got us all started. So thank you very much for listening, and I will stop sharing.
Thank you very much, Dr. Levin. That was a really excellent introduction to these really interesting clinics, and I'm sure there'll be a lot of questions coming out about those from the audience. Our second speaker, we're going to move to Dr. Walter Wodchis, who's a senior scientist and holds a research chair in implementation and evaluation science at Trillium Health Partners Institute for Better Health. Dr. Wodchis is no stranger to the CHSPR conference. I'm not sure which appearance this is of his, but it is certainly not his inaugural. Today, he's going to be discussing his work from Canada and New Zealand regarding the policy enablers for integrated care. So over to you, Walter.
Great, thank you very much, Mike. Yeah, and I think this is my probably my 5th attendance and my 3rd time speaking. So there's good reason for me to come. Hopefully you can see my slides and hear me just fine. I also, as with Tess earlier, I'm speaking to you from Toronto, which has been the traditional land of the Mississaugas of the Credit, the Anishinaabe, Chippewa, the Haudenosaunee, and the Wendat peoples, now home to many diverse nations, First Nations, Inuit, and Métis people. I am going to, I've really appreciated that introduction to integration of research and practice. And I wish I had set up slides to key on that, because I could go for a while on learning health systems. But instead, I'm going to talk to you about some of our international learnings from case studies and go ahead with this a little bit. I'm going to start off with, I'm going to actually fly through 3 broad areas of learning. First was a 7-country study of integrated care programs, and this was primarily at the program level. Then I'll spend more of my time talking about 9 case studies of integrated care in Ontario, Quebec, and New Zealand. That's our iCoach study. And I'm going to talk a little bit about the policy angle. Sabrina was asking about that, and we probably had the best policy work done there. And I'll queue you up for tomorrow's keynote with Tim Bensel. I'll channel him for a little bit. And finally, our most recent work was these 30 programs in 11 countries around the world. And I'll just highlight in key learnings we've had from each of these. I will possibly speak fast, but I'll try not to get out of control. My emphasis here is on integrating health and social care services to meet the needs of individuals with complex health and social needs in community settings. And what have we learned from this work? I'm going to pause because I was on for Dr. Foray's talk, and I saw the questions around integrated care, and I'm like, okay, well, I can adapt and let you know, what do I mean by integrated care? So I just added this, but it comes from our iCoach model of care paper. And in our view, ideal models of integrated community-based primary health care, and that's mostly what I'm going to talk about. They're comprehensive, person-oriented, they're inclusive of carers and family, they're health-promoting, strengths-based, and without a singular disease focus, just so you know what I mean and the programs that we are interested in. They also address problems of inequity in health and risk across population subgroups. And all of our work has really been premised around this focus on integrated care. So part 1, programs. And you can read on these 7 case studies, both from the King's Fund, and there was also a International Journal for Integrated Care article summarizing Cole's Notes version of this. In this work, we set out around the world and we said, where are the best exemplars of integrated care? What are they doing and how are they doing it? We described the models, think about information management, how do they involve providers, and collected a few other pieces. I'm going to cut right to the key findings and what we learned. So our recommendations coming out of this was that there should be a focus on clinical integration rather than organizational or structural integration. And that's just the fastest way forward and to start to build, and I'm going to say this a couple of times, trusting relationships. You require some organizational and leadership partnership on this, but having it focused on what are we going to do for Mrs. Smith, for Esther, or other examples that we've seen around the world has really been the best way to move forward. And actually, I heard one of your own colleagues earlier, Morgan Price, talking about how they do clinics based on this model. Second thing, success appears to be related to good communication and relationships among those receiving care and the professionals and managers involved in delivering care. And then effective models employ multidisciplinary teams with well-defined roles and joint responsibility, and one might say accountability for care. So I think that picks up a few themes that we actually heard on earlier today. And here's a little bit more around the process of how people came to do this. First off, what we found that integrated care was a bottom-up initiative that coordinates care at the local level for shared patients. But it's enabled by system-level priorities, funding, and technological supports that themselves enable and remove barriers to sharing information and care. This takes time, and it's an ongoing process, expanding the horizons of what kinds of care is integrated and expanding the focus from individual to population health. Those are some of our keys from the first summary. Based on that work, we went and undertook some very in-depth case studies, 3 cases in 3 jurisdictions, and we spent several years at this. So we really got to know these cases. Over 600 interviews with patients, caregivers, providers, managers, leaders, and policymakers to understand how to implement integrated care programs. We saw what success looked like, but we didn't quite know how to get there. And a lot of our work is in this IJIC special issue, not all of it, but you can find, I think, a good summary of it in that special issue that we published. I'm going to talk about 3 policy contexts that we found, and then some of the key pieces. And this comes out of Tim Benzel's paper, so he gets credit, and the omissions are probably mine. He'll speak to this much more, I think, brilliantly tomorrow. First off is the Ontario policy. So Ontario has interprofessional primary care in relatively limited practices, about 100 community health centers and about 185 family health teams. That covers about 30% of our population. And otherwise, we have mostly small physician practices. Even if they're aligned with groups, they're not really practicing in any form of team. We do in Ontario have fairly comprehensive funding of home and community services. And you'd think here we'd have in place the elements of a broad continuum of primary health care. But the elements continue to operate relatively independently with no overall coordinating strategy and few mechanisms to integrate client care across providers and settings. And to Tessa's defense, even as LHINs and now regions of Ontario Health are moving ahead through Ontario Health teams or otherwise, they still only really hold the payment and the policy primarily in the team-based environment and in the other healthcare settings without any direct involvement of physicians. What about in Quebec and in Canada? We've learned a little bit in Quebec. They've really had a top-down policy orientation. They've done a really brilliant job of trying to make things uniform. They had early aims to integrate health and social services into community health centers, the CHSPR. Unfortunately, physicians didn't like to join them. So then they moved to promote primary practices through family medicine groups with additional health services providers, such as nurses or nurse practitioners, to provide multidisciplinary based care. And most recently in 2016, they've moved to 22 regional integrated health and social service centers. And this actually probably holds the greatest promise by bringing together the FMGs with the other sources, as well as system-wide planning, including hospitals, rehabilitation centers across the board. Still, those structural integrations of all of these components has not meant that people work very well or effectively together. And hence, it doesn't mean that the services are well integrated. Finally, we'll come to New Zealand. And here I think Tim is mostly going to talk about New Zealand tomorrow. So here we know that New Zealand has a single country, single health system for their country, 20 district health boards responsible for planning and delivery or contracting of comprehensive health services from community and specialist care in their geographic regions. They do not have primary health care providers in those. Instead, there are 32 primary health organizations who contract with primary health care or general practice physicians. And the DHBs have multiple alliances with these PHOs. That has generally led to better integration across the board and through these alliances, but still, I think, disjointed in some locations, except for some exemplars such as Canterbury or some other smaller projects. The ones that we've seen have the greatest integration have really been through the Maori, which came out of the Whanaora initiatives. And these have joint Maori community and institutional providers who co-deliver care to individuals in the community, mostly of Maori descent. A couple of the ending reflections from that program and I could spend days because we spent a few years at this, policy contexts can provide financing and incentivize local providers to collaborate and work together. And policy can be a requirement. Policy requirements for shared care planning can provide a top-down strategy. But at the end of the day, we're still left with this notion that integration itself is a bottom-up initiative built on trusting relationships and enabled through co-design and co-delivery. The last piece I'm going to touch on here are some international learnings that we have from these 30 programs in 11 countries. These were published in Health Affairs, and I checked, fortunately they are now public access. Sometimes that's not true in Health Affairs. So here, when we think about the program elements that were quite consistent across the programs, the first thing we found was that the programs had segmentation. And by segmentation, I mean they had clear the practices that didn't only say identify the people who are already receiving care, so outreach programs. The second thing they did was to really focus on the coordination of care, and that included program intake assessment and planning at the individual level, and coordinating health and social services centrally for each patient in a patient-oriented model of care. And the last thing they did very, very clearly was patient and caregiver engagement. And by this, I mean that there was support for shared decision-making between patients, providers, and caregivers. There was support for patient self-management, and there was support for caregiver supports as well in the most effective programs. And these worked in collaboration to have successful programs across these different initiatives that we saw. The paper I led on this, I was co-author on this one, but the one I led focused on policy. And we found that the key policy supports for these programs had both top-down and bottom-up perspectives. So from a top-down, there were often bundled budgets provided to organizations to deliver on health and social services for a defined population. And how did this look at the bottom-up? Well, they found there was local discretion in spending. So in New Zealand, as an example, there were programs that received a global budget to care for the population. And then at the individual level, they actually had discretionary funds that they could hand out to individuals, and they had money that they spent, for example, on keeping people's gym memberships or paying for them to go to the pool, or if they had a debt from their pharmacy bills, that they could pay that debt on behalf of the patients. The other thing we found from a human resources perspective is that there were revised staffing models from the top down. So new care providers were being funded and financed, such as care managers. And at the local level, we found people being redeployed into these new roles. For example, in Australia, they had programs where hospital staff were working in the community to support patients. The other thing we found was around governance and accountability, that there were clear goals and aims and support set by the governmental authorities to have interorganizational governance and accountability mechanisms. But at the front lines, this looked like local steering committees, local partnerships that came together, looked at data, and found ways to solve local problems. And the final piece was around use of data. And we really found that on an external, in a few cases, but not very robustly, did we see rigorous external evaluation. It was true in a couple cases, but not all that much. But what we did see a lot more of was local quality improvement, people looking at their data, monitoring, making changes, and that data being available to the steering committees to really hold local providers accountable for the work that they were doing. So I'm going to come to a close with a few closing remarks on that last piece with these 30 programs. First was to recognize the importance of addressing the agenda of integrated care for populations with complex needs. We found this was true whether people were focused on older adults, people with multiple chronic conditions, people with disabilities, people with mental health and physical conditions. The second thing was for the governments to provide stimulus through funding or other means to support the development of local initiatives to improve care. And by government, I mean government and agencies, such as regional bodies that hold funds to support this work. The third thing is that initially to avoid a top-down policy that requires structural or organizational mergers at the outset, that really slows things down. And in fact, programs can be years in the making before any change is made to patient care if they're stuck in that structural or organizational merger. And the last thing is to remove the barriers that make it more difficult for providers to integrate care, such as differences in financing and eligibility of patients for needed care across the different providers that you're trying to have collaborate and work together. So key takeaways from me today. First off, the care integration is realized at the patient and provider level. And improving integration requires resilient, trusting relationships between patients, caregivers, and providers, and amongst providers with managerial and leadership support across what are often distinct organizations. Providers and patients suffer from inertia, and they're going to require some stimulation to break out of existing patterns. If you want to do this at scale, you need to provide some incentives, some policy supports. And policy priority in this space, resources and supports, are accelerants. So I'll close off there. Thank you. You can check out our work. We're very involved. People are asking questions about OHTs, doing a lot of OHT work these days with our network, and I'll be looking forward to some questions later. Thank you.
Thanks very much, Walter. That was a great talk. And it's my pleasure right now to introduce our final speaker for this session, Dr. Carolyn Steele Gray, who is a scientist at the Bridgeport Collaboratory for Research and Innovation at the Lunenfeld-Tanenbaum Research Institute and an assistant professor at the Institute for Health Policy Management and Evaluation at the University of Toronto, and who has instantly gained my respect and admiration for the number of bicycles in the back of her screen when she was sharing her camera a few minutes ago. Today, Dr. Steele Gray is going to be speaking with us about the importance of digital health platform for integrated care. So over to you, Carolyn.
Thanks so much. I don't love the backgrounds that you can put in because it always cuts people off a little bit. So I just deal with the fact that I'm in a basement. So thanks so much for having me today. I'm excited to talk to you all about digital health in the role of integrated care. And I will be talking about some exemplars, some from the iCoach project that Dr. Wodchis just talked through, and then some other international examples. But I want to start a bit by helping understand what digital health tools can do within an integrated care model. We use these terms a lot, and these are the kinds of definitions and the concepts that we tend to see most in models of integrated care. So we'll talk about e-health technologies. Those often refer to information communication technologies and other things that support documentation and information sharing. You'll also see terms like mHealth, that's things that use mobile devices or apps to do monitoring or to do GPS work or anything that you can kind of take around with you. You'll also see concepts like telehealth, telemedicine, telecare. We're already talking about the role of virtual care, and I'll dive into that later on in my talk. But that can also count as phone care. So anything that's done over the phone is also in that kind of bucket of telehealth. We talk about health records that can be electronic medical records or at a higher level health records if they span organizations, and then patient personal health records. You'll see terms like health information exchange when those systems can talk to each other, big data in health. I know CHI is one of the sponsors for today, and they've got a big data repository. And when we're talking about the use of big data in health, that's one of those spaces that we would engage in. And then, of course, artificial intelligence in healthcare. And all of those terms are being used in being applied in integrated care models locally and internationally. But what does that really mean for integrated care? So I'd like to kind of position those technologies alongside this rainbow model of integrated care that was presented by Valentin and is used by a number of us who study in this space. And this is a useful model for us to understand integrated care. We can see that it's placed at from a micro to macro level, that integration is vertical and horizontal, whether at the clinical and professional levels, then all the way up through organization and systems. And what's useful about this model is if you can look along the bottom, you see two kind of key pieces around functional integration and normative integration. And what the rainbow model suggests to us here is that in order to enable this vertical and horizontal integration across these levels, we need to enable these mechanisms to do that. And on the left, the functional integration mechanisms are those things we tend to think about, like the activities or the actions that we do, the new systems we put in place, the new policies we've put in place to enable that type of integrated care. And often that's where we tend to put digital health tools in the processes of care. So at the clinical and professional levels, we'll imagine the use of electronic medical records, of those messaging systems, of mobile devices and telehealth systems that will allow us to support care coordination at the level of the patient and their families, and then support professional integration to allow providers to communicate with each other within and across organizational boundaries. Moving up a level, if we can connect those systems between organizations, we can enable organizational integration, allowing them to support care delivery, but also through connecting operations and information sharing. And then up at the system level, this type of data can help with population health management, can help with the segmentation piece that Dr. Wodchis was talking about. But even more broadly, we can start thinking about e-communities that connect health and social care across a broad range of populations to support that kind of integration. So indeed, technology really does help that side of the integrated care implementation. It can really do a lot to support those types of pieces, but it also plays a really important role in this normative integration space, so the normative mechanisms that drive these integrated care models. And by that, I mean the values, the beliefs, the shared aims, when we talk about relationships and trust, all of those more affective pieces that can move people and systems and organizations towards integrated care. And we might not see it right off the bat, but technology is a social artifact, that it is shaped by the place in which we put it in. So it's shaped by our context, but it also has the power to shape the context in which we apply it. So the types of technologies we put in front of people, whether our patients or our providers, can play a big role in changing the way they engage with their care, the way they engage with each other. And so it has this really important kind of affective piece. And for when I talk to people about, you have a relationship with your technology and they disagree with me, I would encourage you all to think of a time where you've maybe yelled at Siri or Alexa in the last couple of years, and you'll understand the real emotional connections we have to our technology. So I'm going to talk through how we've seen some of this digital enabling of integrated care in the pre-COVID times and in the post-COVID times, because in the last year, things have changed so drastically, and it's in a really important place for us to kind of plant our knowledge. So before all of this happened, we conducted a deep dive into that iCoach study. So I led a small team of folks who looked at that data from those 9 different cases. So as Dr. Wodchis talked about, we had 9 exemplar cases, 3 in Ontario, 3 in Quebec, and 3 in New Zealand. And we asked, how were these exemplar models using their technology? And what were the implementation factors that were shaping that use? So we looked across them and engaged with almost 140 different interviews with providers and managers to pull out this data. And we did see examples of data being used and digital health systems being used to enable integrated care across all of those levels of the Rainbow model. We saw clinical decision support tools in place. We saw self-management support tools, and all the way up to system information sharing to allow for population health and planning. So these were looking pretty good, especially in New Zealand, where they had more centralized data systems. And some really great examples of care coordination being used across. But as we kind of dug deeper into this study, what we were finding was that the way people were choosing to use the technologies in front of them was very interesting. First, in terms of care coordination, they were all using some kind of care coordination tool, but these were often static care plans that sat in single EMR systems, which actually made the clinical and professional integration work quite challenging if the information just kind of sat in one place. They were using clinical decision support tools, but often they were around accessing evidence-based guidelines, which may or may not have been useful for that more holistic approach to care that Elder Price was talking about earlier today. And finally, all of the systems were using data to some degree to support quality improvement, but the way the data was being used, the type of data that was being collected, was valued differently by different people. So really useful from a managerial perspective, but not always as highly valued by providers and their patients who were being asked to collect that data over time. So we brought an implementation science lens onto this to understand it a little bit better. And from all across the different systems, we saw very similar implementation factors in place. But I'm going to talk a little bit about the policy drivers here that led to a particular use of technology. And we did that through exploring kind of implementation narratives. We looked specifically at their use of information sharing to support care coordination. So how were they doing that? And what were the policy drivers behind it? So I won't go into too much detail because Dr. Wodchis already did that work for me. But generally in Ontario, we had this situation of a light touch policy environment, lots of grassroots interventions, which did lead to quite a bit of fragmentation in the system, as well as in the types of technologies that were being used. They would tend to be organizational specific. At Quebec, we had, because of that top-down approach, there were more centralized government initiatives and more digital assets that could be shared at a regional level. And in New Zealand, you see this kind of blend of top-down and bottom-up. So there were lots of integrated care models that were based, the integrated care models were based on local initiatives, but they had those centralized data assets. Now, all three of these jurisdictions did have very strong legislations and regulations around patient data, privacy, and security. And this is absolutely critically important. It did shape how these uses of technologies were put in place to support integrated care, though. So in Ontario, this meant the combination of the policy environment and these regulations meant there were lots of workarounds, lots of multi-step connections, lots of kind of band-aid solutions that were often innovative, but not necessarily scalable to another place. In Quebec, although they had centralized data assets, there were lots of permission barriers. So a social worker couldn't access the data that their primary care provider on their team had collected. And that created a lot of difficulty to deliver that holistic care. And then in New Zealand, they were getting closer, especially enabled by having a unique patient identifier, which meant that all of the patient's data from across the system could be connected to one ID. However, they still were experiencing those professional restrictions, which led to workarounds and a number of challenges. And then finally, it was very difficult to overcome organizational and professional inertia in all three spaces. So in that slide before, where we were kind of questioning how the systems were being chosen to be used, it really came down to this kind of well-documented phenomena where people will tend to work the way they know how to work, even when presented with innovative solutions or new models of whether technological or not, that we tend to work the way we know how to work. So they were kind of using technologies to enable existing ways of delivering care, as opposed to driving forward more aggressively their integrated model. So that's kind of how things were going in the before times. What about now? Because things have been very different in the last 12 months. And this is a table from a paper that was recently published just a couple of weeks ago by Dr. Rick Glazier and his team. It was published in CMAJ that documents the use of virtual visits in primary care in Ontario in the early days of COVID. And what you see is a very drastic rise in the use of virtual care, understandably, in order to continue to deliver care in a very different environment. They also cite a previous pilot study from Women's College in which patients had chosen to do way more texting asynchronously. So what we're seeing is very different types of behaviors around the use of technology and care delivery than we had seen ever previously. So what this is starting to show us is that we're kind of coming out of that organizational and provider inertia, that COVID may be disrupting that status quo that was impeding our ability to use digital technologies to drive our models forward. But what about the policy inertia? We all know this is a very big challenge to move policy enablers and very quickly or at all. So in 2019, the Canadian Medical Association identified several system level barriers to wider adoption of virtual care. This is of course one perspective of many of the types of policy enablers out there. And they identified payment mechanisms, licensure requirements, and interoperability as their key barriers. So how did we do with that in the last year? Well, in Ontario, we saw a very drastic grouping of changes that addressed a number of those issues. Within days, we saw temporary virtual care billing codes being put in place, as well as broader allowances on the types of platforms that primary care systems could use to engage virtual care. We had a huge omnibus bill on March 25th of 2020 that created amendments to privacy and security legislation and expanded the ability to link data across platforms. And then just a week or so after that, we have the Ontario Health Data Platform, which created a precedent for linking large data sets at the patient level in order to enable COVID-19 patient care. So we see, addressing the payment mechanisms, we're seeing a precedence for interoperability, and the cross-provincial licensure argument, not so much, but this is an Ontario-based conversation. And of course, if there are examples of the cross-provincial piece, I'd be keen to hear about those examples. So we have this opportunity in front of us where we're getting upended a little bit, and we could see a broader adoption of technologies to enable these different activities of integrated care to support both the functional and normative aspects of it. But there's also quite a bit of a risk if we don't keep in mind this longer term vision of what our integrated care model could look like. And we have those great examples that Dr. Levin and Dr. Wodchis talked about just now about where we could get to. And if we keep that in mind, we can use these technologies very well. But if we lose sight of that, when we're working in a rapid environment, we can actually end up putting technology systems in place that lead to greater fragmentation and increase inequity within our system if we're not careful about what these technologies mean for different populations and different organizations and teams across our system. And I'm going to leave us with one last example of integrated care, digitally enabled integrated care in Catalonia. So they've been doing integrated care in Catalonia and Spain for a long time, well over a decade. And they're, and for me anyway, a shining example of digital health enabled integrated care because they've been thinking about it from the beginning. They didn't put their technology, they didn't put their integrated care model in place and then a few years later think, oh, we need to put some information systems to smooth out the edges to make this run more efficiently. They actually had a data plan in place alongside building the model. So they engaged in co-design with hundreds of patients and families early to develop their personal health records for their patients. They engaged with their primary care and hospital-based teams to help to develop the data linkages that they use today. And they've been continuing that kind of co-design of their technology alongside the development of their model as they've engaged in continuous iteration of those technologies over time. And they're constantly learning. They have that learning health system approach as well that all enable their ability to do this effectively. And I'm just going to leave us with a little plug for a place where you could go for more information about the use of technology to enable integrated care. I'm fortunate to co-lead a special interest group specifically in this topic, and we have several webinars that dive deep into things like interoperability and engagement. And coming up in April, we'll be talking about scale and spread. So you can connect with us there and look at some of our tools or some of our information that we've been developing with our international partners. But I look forward to our conversation today.
Thanks very much, Carolyn. I'm just going to open up the Slido for everybody to see the questions that have come in so far. Please feel free to submit further questions for me to consider. I will be doing a blend of going from the top of the list as well as spreading questions around to our three panelists. So if I don't choose the one that has the most votes, now you know why I've chosen something else. The top voted question we'll start with here is for Dr. Levin, and one of our questioners was curious that the 3 post-COVID clinics are all located in Vancouver. How does this ensure equitable access for patients outside of the Lower Mainland?
So great question. And so that was where the bulk of the hospitalized COVID patients were in terms of our second wave. We never really had a first wave. There's a buddy system, and we're actually enabling access to those clinics from outside. And we're just about to create additional capacity in interior health in the island. So we've organized a buddy system in terms of locating the expertise and the knowledge gathering based on the greatest number of patients. And therefore, that's why they were physically located there, but they're expanded and they're accessible to anyone, no matter where they are.
That's great, thank you. Dr. Wodchis, the next question, how much of the integration you see elsewhere perhaps in your examples, perhaps elsewhere, is because of single health systems? Do our provincial systems or the organization of them make this tougher?
Excellent question. And if you start to spend time studying international systems, you'll see that while it looks like there are single systems for health, in the space that we're working in, which is that integration between health and social systems, you will find that they are not fully integrated across the world. So in fact, social programs are often municipally run in Europe, and then they have health systems. So they all have barriers to work around. There are some exceptions for sure. Scotland is an exception. So I would say, do our provincial systems make it tougher? Not entirely. I think the biggest barrier that we have in Canada, which is universal across Canada in every one of our provincial systems, is the independence of the physicians and their budgets from the other components of the health system. And that is a difficult barrier because they are paid in different ways for doing different activities. And rarely do we actually say, you know, here's payment for collaborating with other parts of the system. In some cases, people do have those opportunities, at least if they're on salary or capitation, but it's not that universal or clearly expected. And I think that's probably our bigger gap in Canada. There are ways around these, and all incentives are not financial. So knowing that people can get better care, and if I talk to doctors about, you know, what makes their day a good day, it's if they can get good care for their patients. So if we can create systems that collaborative care leads to that, then their days get better. And as Dr. Fourier mentioned earlier on, the lack of sustainability of programs is often that we don't pay enough attention to providers' experiences. So that would be my shorter answer to that.
So, Walter, can I push you a little bit on that? And you said there's ways around it. What ways do you see?
So I think incentive funds for collaborative models, for example. So your daily salary gets paid the way that you are providing service, but you have new funds that are made available. As an example, right now in Ontario, for Ontario health teams, they're handing out, well, I'm not going to get this number right, but it's in the range of like $500,000 a year to each Ontario health team per year. It might be a little more or less than that, but and they can use that money to pay doctors to show up to meetings, coordinating meetings. They can use it to pay patients to show up to meetings and coordinate care. And start to move these pieces ahead. So that's a small slice in there, but I also think that eventually, I mean, for full integration, people need to be probably very closely aligned in terms of accountability to the same organizational interests. But I would say that the incremental piece is to start to allow funds available that can be used for those types of payments.
Thanks very much. Dr. Steele Gray, I have a question for you here, which is that we have stumbled for years with EMRs and other digital technologies in Canada. How much of it, well, first of all, if you can answer whether or not you agree with that statement, and then the next one would be, how much of a barrier do you think that represents to integrated care?
Oh gosh, it's such a big question, and I think those of us researching in the space have been just digging at it for decades, because the different implementation factors that go into why an EMR system is going to work or not are varied, and they're very contextual. It's really about the people, the organization, and the system in which they're going in. So I agree, we have had lots of stumbling to get EMRs or other health systems in place. But we've also had some really good examples of people who've done it very well. And I think part of the challenge is thinking about the timing of this. So I remember, maybe 10 years ago, HIMSS did a presentation where they talked about the return on investment of an EMR system in a large hospital. there's always a dip. It's like a J curve, right? It always goes down, efficiency goes down, everyone feels terrible because you're doing something new. And then all of a sudden you start understanding it and it like starts working really well. It's like anytime you put a new app on your phone or learn a new software system just on a much larger scale, you have to kind of go through and learn and understand its value to you. I think one of the ways it works well is when you're careful about the kind of co-design of the implementation. So even if you're not developing the technology, but if you're co-designing its implementation, you're working with the people who are going to be engaging with it. You're thinking about the value that it brings to those folks. There is a wonderful model of implementation done by a colleague of ours in Toronto, by Dr. Jay Shaw, that talks about value-based design and how we can think about the value to different people that will drive implementation over time. That is some of the ways that we could potentially get over that. But I think it needs to be a continuous conversation about our systems and who they're serving and the role that it plays in delivery.
That's great. Thanks very much. So I'm going to ask a question for all three of you now, and I think it's a broad question that all of you touched on lightly, but I think people would like to see a bit more of here. So you mentioned fights over data privacy. I don't know which specific speaker that was referring to, but how have these issues impeded care integration in the examples you've looked at? Like, I think we all recognize the importance of data privacy, but how is it a barrier, and what, if anything, can we do to overcome that as a barrier? So Dr. Levin, do you want to start? We can go in speaker order.
Sure. There's something in BC called the COVID cloud where we can put all the administrative data, and then that's accessible for various purposes, but not for everyone's purpose. So that's an issue. The data privacy, this whole notion of if you're being seen in a health authority-based clinic, then the data goes into this provincial network information system. So now that gets away from some of the territorial privacy things. I think what Dr. Steele Gray actually spoke to earlier, this notion that everyone, like if you go to the UK, or there's one information system for all of primary care in the entire country. The fact that in this country we can't do that is hugely problematic. And I think we'll get over a lot of our privacy issues, because then it's a public system, therefore we need to be accountable to the public purse for the care that we're giving. And I don't know why we have to always get balled up in privacy when we're trying to improve a healthcare system, but that's long, short answer.
Yeah, I mean, I'll speak first to some of the impediments that we've seen, and then maybe some of the ways people have done workarounds in this. Many jurisdictions we have seen have the exact same arguments, that people are responsible for the health information for the patients that are within their organizations, institutions, or immediate care circles, and sharing that outside often creates concerns and challenges. One with privacy, and just on the account of this is, information, but also actually a concern with, if I share information across to you, are you then accountable for having acted upon that as a healthcare professional in response to that need? Which, that's another high barrier, right? So depending on how we expect that data to be used initially, as opposed to informational or care planning purposes and sharing. Generally speaking, the first step forward is allowing view access, and then view access with some commentary, and it's still kind of notes as opposed to directing, you need to do this. And then there are then the examples finally of the most integrated systems, like the Kaisers of the world, where communication is flowing quite rapidly around for patients around their information. But just as an example, even in UK, they may have a single data infrastructure for primary care, but there actually are multiple software programs that the primary care docs are using. And in Northwest London, one of the great examples of putting data together for a region in England, they had 63 data sharing agreements that they had put in place over the years in order to be able to do that. So even there, they had their work to do.
So yeah, I mean, I echo the comments of Dr. Levin and Dr. Wodchis that bringing things together, single data spaces, and overcoming these challenges is a big one. I think the only thing I'd add to that is the lens or the perspective of what we mean by data privacy. Who are we asking about about why that it needs to be private. So often we'll have assumptions about what patients don't want to have shared without actually asking them or asking their caregivers. And I've been in lots of wonderful co-design sessions or sessions with patient and family advisors where they've said, I would like my information shared more readily if it's going to actually improve care for myself as well as improve care for my community. But nobody actually asked me who is allowed to share this information or who can have access to it. So when we're having these conversations about privacy, I think bringing in the people whose data it belongs to, which is the patients and their families, as well as the providers who engage with it, and the full system to understand how we can do this well.
Parenthetically, when you ask the COVID patients, they're surprised that we're not going to use their data. Like they just can't believe that they're not allowed to register and just be a part of something. And so I find that quite curious when we're so concerned.
Yes, I hear that a lot in lots of spaces. Mm-hmm.
So do you think the pendulum has gone too far then?
Oh yeah, I mean, like I think people expect providers to be sharing, but they do want the option to be able to shut it down in some cases. So I think that's really the way we need to have clear communication with patients and engagement around how does that work.
Yeah, and I guess I would say that we're talking about responsible use of data. We're not talking about irresponsible use, so there'd have to be some checks and balances. But I do think some of the privacy stuff has been interpreted incredibly legalistically and very risk averse, and actually to the detriment of patients. So I think there needs to be some better conversation about it.
So there's a wonderful document that was done by the Beacon Support Unit, SPORE Support Unit in Ontario that was led by Elise Maybe and a cohort of patient and family providers that talk a lot about how we can do privacy and security from a patient lens. And it has a whole host of recommended ways forward. I'm happy to find that resource and share it if it would be of value.
That's great. Thanks, everybody. So Dr. Levin, our next question is directed at you, and the question asks, how are practitioners working within the pilot project compensated? Were incentives needed? And if not, do you think they would be needed to expand?
That's a great question. We actually started by having, there's something in BC called Doctors of BC Healthcare System Redesign Funding, as well as a number of other initiatives that pay physicians to think and sit and redesign systems. And so amazingly, you can get a group of well-intentioned individuals to do that if you pay them to sit in a room. So that was those were the dollars used to help create and continue to have clinicians involved in healthcare system redesign, shared care protocols, et cetera. And the actual funding is on a fee-for-service model. So, and the teams like the social worker, nurse, data entry, et cetera, are funded by the health authorities. So it actually was, the concept was an integrated team from the beginning. It was never physician only. And so there is some support from health authorities for those other resources.
That's great, thanks. So Walter, the next question here for you. You mentioned co-design in your talk. Any thoughts on what good co-design actually looks like?
So I'm going to give you one example, and then I'm going to give you Carolyn, because Carolyn's my best example of co-design. I'll say, one of the places we see it, I'm just going to highlight this one example, was around, it was a narrow, not full-blown integrated care models, but a pathway of integrated care for cardiac patients in Mississauga a couple of years ago. And they've still got this model running, and they iterate it. So when they were looking to design, they made sure that they had the right people at the table. So they had the patients and caregivers, they had the nursing and PSW support workers from the community, and the nursing and physicians from the hospital, and agreed to what were each of the pieces of activity that each could contribute to. And they actually didn't really know what each other had done at the beginning. So actually one of the things on co-design comes back to, there's another question around how do people build trusting relationships. One of the things they did is they job shadowed people into each other's environments. So the hospital nurses went into the home care and said, this is what happens to your cardiac patients after leaving the hospital. And those home care people came into the hospital to see the flow of what was happening ahead of time. And then out of that, they decided on what the whole design would look like. So to me, you have to actually learn about what each other does and their capabilities as well. That was the one example that I would just highlight. But Carolyn's led us down the way, quite a bit in this area. So I'll ask her.
Thanks. I can talk about this from a broad piece. We've been doing co-design of technologies for a really long time, and we're now co-designing another technology-supported transition model to connect hospital to home in Ontario across several organizations. But fundamentally, co-design is kind of about understanding that the answers to our problems probably lie with the people who are experiencing the problems, and that we likely don't entirely understand the problem until we talk to the people we're trying to serve. So if we recognize that creativity and understanding can come from lots of different places, and in particular the people who we're trying to serve most, then we can engage them through kind of an iterative process of focus groups and interviews and design sessions. And we're going to be engaging in virtual co-design where we use online whiteboards and different kinds of ways of engaging. And at the end of the day, trying to understand what the need really is and how we've worked together to iterate a solution to that need.
Great, thanks. So the next question, Carolyn, also goes to you. If inertia is an issue, what are your thoughts on the best way to get past it? Incentives, orders, something else?
So it's actually not far from the answer I just gave about understanding the people that you're trying to work with. Again, inertia has been a problem, and we see it in the organizational behavior literature for absolute decades. It's very hard to move people. But the examples that we've studied where people have been able to shift their behaviors and then in turn their organizations and systems have been able to shift is when you take the time for people to sit down and engage with each other and understand their needs. Exactly as Dr. Wodchis was saying, where people job shadowed and understand each other better. And then they were able to move more readily because they understood what the need was. One of the examples I was going to talk through today until I kind of shifted my talk was a model of care in Vermont, where they used goal-oriented care as an orientation to support integrated care. And that was allowed them to move out of their comfort zone because they spent a long time building trusting relationships, understanding each other. And so the incentive became around serving their shared patients, their shared clients, not even really about new funding or about different kinds of accountability structures. They were really driven as a group by a shared vision and shared aim and a belief in that aim. So that's one way to kind of get people out of their ways of thinking, is just show them a new way of viewing it. And again, as to Dr. Wodchis's point, that was shadowing as one great way of understanding that.
That's great, thank you. This next question was originally targeted at Dr. Levin, but I'm actually going to ask it of everybody. Can you speak more to the involvement of patients in the different parts of, in this case, your network and clinics, but in the for Walter and Caroline, in the examples that you've cited in your discussion?
Yeah, so for full disclosure, I'm also part of a SPORE network grant for kidney diseases. And so I've had a lot of experience involving patients in research and governance structures and other things. So we use some of that learning in the network development. So we have the patients at, as I said, the governance level, helping the researchers to make sure what is the burden of the research that's getting done, and helping us to develop LACE summaries so patients know what they're signing up for in the context of the clinics as well. When we're designing the clinic flow and the frequency and the tools that we were using, we had a group of 4 patients, 2 at risk for COVID and 2 who'd survived COVID. The 2 who are at risk actually are used to chronic disease management. And so making sure that the burden of the clinic visits and the frequency, et cetera, were all in the context of what was acceptable to individuals. So that's sort of examples. I find patients are very interested in research and data, and the fact that clinicians don't have to actually apply best care practices. And when you bring them to a meeting where there's a best practices discussion and they get quite excited about the fact that we have the option of not actually implementing therapies or strategies. So they sober a lot of the clinicians.
Yeah, I think some of the models that we've seen that have been particularly strong have had a combination of quantitative and qualitative data at the outset. So both people looking through their healthcare utilization to say, here are people that we think may be falling through the gaps. They're showing up on, often in the emergency departments or unnecessarily. And then they find those people in the community and say, what's going on? Tell us your story. And then they can bring that story to a group that has, clinicians representing a wide array to say, this is the problem, as Carolyn said, this is the problem we're trying to solve for, as opposed to just people saying, hey, we hear this new evidence-based pathway, we need to put that in place. But it's that involvement at the outset. So we're really oriented around what I call person-centered integrated care, person and caregiver-centered integrated care, that allows you to know you're dealing with a problem of substance quantitatively, but also that you're understanding what is the problem that is actually happening, because showing up to the emergency department is not the problem.
So I think patients and families can kind of play a role in all kinds of parts of the network and kind of problem ideation, as we were just speaking about. But also we've seen great examples of patients being on boards or on decision-making groups, in being part of kind of understanding data that gets pulled in as part of a learning health system. And in any of these instances, I think it's really important to ask who you're engaging in terms of your patients and caregivers, and are they representing the group that you're trying to serve? There's a large conversation coming around equity in terms of patient and family engagement. So I would encourage patients being involved in all parts of the network as much as possible, but also with an eye to ensuring there's some representation of the community in which you're situated.
That's great. So I have lots of questions here, and so I'm going to try and get through a couple. So maybe some quick answers on these here. So Dr. Levin, can you expand on your plans to virtualize the patient journeys through ongoing monitoring experience and et cetera?
So we're going to, first of all, there's standardized visit frequency, and we're actually allowing people to choose virtual. Otherwise, for various reasons, people have preferences as to either never ever coming to the hospital location again, or to absolutely having physical contact with people. So that's been customized, and the reporting is when we have a large enough cohort of people with meaningful information, we will report first to the patients and the care providers, and then more publicly. The peer supports are part of an ongoing thing, and you'll find a lot of the materials are actually all designed by patients with patients, and as I said, the visits are standardized. So we're attempting to virtualize and customize at the same time.
Great, thank you. Walter, what processes or mechanisms did they use to build these essential relationships that you talked about?
Thanks, Karen, for your question. I think that's the Karen I know. Two pieces. One is I've already talked about, understanding each other's roles and responsibilities and capabilities. That's essential to have trust. And the other, and I'll take this from the Netherlands, and there are examples of integrated care and population health initiatives across, I think it's 8 or so regions in their country, and they're using a regional model to implement, because they know fundamentally it's frontline relationships in the communities of the people they serve, that they are doing it with small tests of change, right? They're saying, here's something that we can do in the next 6 months where, so many of us, 3 or 4 or 5 different groups or types of providers need to collaborate to do this well. And we're going to do it for these 100 patients. And by starting there, they start to allow themselves, the opportunities to work together and build trust. And there's a great Dutch saying, because you need to do this well, trust comes in on the back of a turtle and leaves on the back of a horse.
I love it. Doctor, a question for you here. Is there any initiative in Ontario to evaluate OHTs on virtual care? Will there be any indicators looking at virtual care use with funding tied?
So I'll get a chance to now throw back to Dr. Wodchis because he's leading the evaluation of the OHTs in Ontario. What I will say very quickly before I throw it to you is that I did have an opportunity to look through some of those data collection tools and did provide some feedback on the types of survey and interview pieces around digital health. But his team is great and they asked most of the questions I would have asked anyway. But Walter, perhaps you can fill in some more of the gaps on that one.
Yeah, very quickly, we do have an indicator of virtual access to care, which is really primarily a measurement across all OHTs on the measurement of the billing codes that Carolyn mentioned before, and billing codes that existed prior, because we actually have seen that there were virtual visits happening prior to COVID. We'll continue to monitor that. I wouldn't attribute what we've seen so far yet quite to OHT, because we haven't seen the data from not very far post-implementation. So we'll continue to monitor that.
All right, so as a final question, I'm going to use Chair's prerogative to ask this question because it's so closely linked to the whole theme of our conference. And to all the panelists, COVID may have disrupted some of the historical, organizational, and political inertia for change. How can we continue this momentum in the hopefully post-COVID world?
I guess this has been my frustration a lot. The momentum started and then it actually waned, to be very honest. And I think that we need to hold ourselves accountable to not going back to what we know as familiar. It wasn't working before and we don't need to go back to it. But I think that there's a lot of people who have investment for lots of reasons in the status quo or the before times, as I also say, Carolyn. So the before times they like and they don't want to change. So I think we need to force people.
Yeah, so I mean, I will say two things. First off, we have seen, not everywhere, not universally, but in many cases, that the people who had come together to start to form their Ontario Health teams took advantage of those partnerships to better orient testing and now vaccine delivery into the communities according to need, taking advantage of new community partnerships that they had developed, and really to use that to make sure people knew about the testing. And some of the things that Tess talked about earlier in the previous session were around this. How did they leverage some of those partnerships developed? So in some places, they've actually continued to accelerate. And COVID-19 is the best example of population health management that I think we have today. So that's what I would say. And for the people who didn't, I think they have to understand that first, the challenges related to COVID were all challenges related to long-term conditions and socioeconomic disparities in health. Not all, but largely. And that moving towards population health, and you can do integrated care without doing population health, but you cannot do population health without doing integrated care. And so I think we have a burning platform to move forward.
So I might suggest keeping an eye on the vision, right? That if we have this vision for longer term integrated care and we see things moving in that direction, and you remind all the players that are really important in this, particularly change agents and people who can move other people, that if we continue down this path, we can continue to iterate that way, that we're more likely to see sustainment of that change. It's funny, we're just finishing up a chapter specifically on how you sustain change after COVID, using some of the literature in sustainability and from the disaster response literature. And the big mechanisms to keep sustainability are things like adaptive leadership, change mindset, really a lot of things aligned with the learning health system. So lots of adaptation, but always with a shared vision to move forward.
That's great. That's a good note to end on. So thank you to all of our speakers for a really engaging and interesting session. Thank you to all of you who submitted questions, and apologies that I couldn't get to all of them. There were quite a lot there. I will just let everybody know that we are having a poster session today, which will start at 12:15 Pacific. And you would have received the link to the poster session in the email you got from Eventbrite. And I see that Joyce has also just posted it in the chat. So if you look in the chat, you will find it there. There is also going to be a second poster session that will start at 12:15 Pacific tomorrow before we reconvene, start 1 p.m. Pacific time tomorrow afternoon. So with that, I will wish everybody a good day and look forward to seeing you in the poster sessions and in tomorrow's sessions.